Next speaker is Dr. Russell. Time to take over. I hope you have something for us new in adjuvant radiation.
Just a few quick points on this. Remember that we're looking at a magnitude of incidence of 100 to 1, right? So we know, or we think we know, a whole lot about lung cancer. We're talking about for every 100 lung cancers, we have one thymic tumor, right? So the data we have is just far less good. First of all, stage 1 thymoma does not require postoperative radiation. Wally Curran published this 20 years ago, looking at stage 1 disease, looking at total resections. They were all totally resected and looked at excellent relapse-free survival. In fact, the only randomized study that we have in thymic tumors with radiation is one from Asia, 29 patient stage 1 disease, resection versus resection and post-op RT. Well, tell you what, when none come back, it's hard to improve on that, right? And so there was no difference in improvement in doing that. So very clearly, there is not a role for postoperative radiation in stage 1 thymoma. If it's encapsulated, you're done. All right, well, how about more advanced disease? This SEER analysis took patients from 73 to 2005, and there was a total of 901 patients, and divided them into two categories, localized, which was stage 1, versus regional, which was 2 and 3. And I think what's worth noting is that the addition of postoperative radiation in localized thymoma made outcomes worse, right? So this is our intervention. The solid curve is not getting it, so radiation was a bad thing. Cause-specific survival worse. 2 points on that. Number 1, stage 1 thymoma does not need post-op RT. Number 2, in the era where these patients were treated, we were using techniques that I agree I wouldn't want my chest given radiation using those techniques either. Okay, well, what about stage 2 and stage 3? In this SEER analysis, we can see now that the curves flip the other way and that postoperative radiation improves survival in these patients. Now, this is, can I call it low-quality data? But it's the best that we have in tumors like thymic tumors. So in stage 2 and 3 disease, the benefit of postoperative radiation is different. This is a different story, and that's owing to the fact that we're not always getting gross total resections in these patients. So stage 2, we're looking at micro or macroscopic involvement, or stage 3, invasion of nearby structures. Okay, so I'm going to show two pieces of data that are going to give us two different stories. The first is a very large study by Kondo et al., 1,300 thymic tumors treated in the 90s. We're going to focus on the stage 2s and stage 3s. And here's what they showed, that gross total resection is good. And now this is important. When we look at stage 2 disease, that plus or minus port, there was no difference in recurrence in stage 2 or stage 3. See, those numbers are equal right there. And so based on this data alone, this would suggest no difference in local recurrence with completely resected stage 2 and stage 3 disease with the addition of radiation. Well, here's what this data definitely shows, that the role of complete resection is critical. But then we have other data, like this study, that shows that in stage 2 or stage 3, when we look at prognostic factors for disease-free survival, that operation alone versus operation with radiation, that we have an improvement when patients get post-op RT, and you can see that in the curves there. And so in these data, the benefit of post-operative radiation in stage 2 and stage 3 disease was seen. So here's what we've established. Stage 1 disease, you don't need it, don't do it. Stage 2 disease, the chain data would say yes, and the Kondo data would say no. Well, two considerations. Number 1, the Ching data came in a more contemporary data sets, whereas the Kondo data was from 20 years ago. And frankly, we just have incomplete data for stage 2 versus stage 3, much less 2A versus 2B. So if I could say, what's something new that's happened in the last 12 months in thymic tumors that's probably notable? Because everything I've told you we could have presented 5 years ago. And it's the ICMIC data that has come out that was published in JTO last year. This was looking at stage 2 and stage 3 disease, 1,200 patients. Probably the biggest, well, it is not probably, it's the biggest piece of data we have in the literature. 70% stage 2 patients with a variety of histologies. And here's what they showed. Again, this is stage 2 and stage 3, that the 10-year overall survival without postoperative radiation was 90% versus 95% with PORT. And the 10-year OS favored PORT as well. Here are the survival curves of stage 2 and stage 3 combined, where operation only in blue and operation followed by PORT is in red. And then when we parse that out by stage 3 disease, there was an OS benefit. Well, maybe it was the stage 3 players that were driving that, so let's look at stage 2 alone. So even in stage 2 alone in this data set, there was a modest but real survival advantage. And so based on these data, I now offer postoperative radiation to patients. I'll say before these data came out, stage 1, no way. Stage 3, I definitely offered it. And stage 2's was this dance of shared decision-making. I think these data really push the conversation forward for considering post-op RT. One other thing, the Kondo data, remember the negative data. They were using radiation doses of less than 45 gray. These data suggest that the higher the radiation dose, the better the outcome. And then just one other thing, a discussion about postoperative radiation can't happen in a vacuum. It needs to happen with the patient and with a consideration of their age, of patient preference, histology. We know that B3s and Cs are going to do worse than type As and ABs. This is how we do it. This is using IMRT, postoperative radiation planning, using important constraints. I now want to say a few words about stage 3 and stage 4 disease. The backbone of therapy in I'm going to call it unresectable or metastatic disease is systemic therapy. And this is based on a number of studies that used a variety of regimens, all of which showed response rates plus you of around 50% or higher. And you can see the regimens here, and we'll perhaps hear about them in a different lecture. A study was done at MD Anderson where this was now almost 20 years ago, where they said, what about giving giving radiation treatment in these patients? And what they found is that 76% of tumors were completely resected and a good PFS. So this is the paradigm that they used right here. Again, we have biopsy-confirmed thymomas registered given concurrent chemorads. If no distant progression, they were resected. And the majority of patients did end up going through for resection. What they showed is a partial response rate of 45% and a stable disease of 55%, 77% R0 resection. Now, I will say if you compare this data to the chemo lung data, the response rates appear about the same and the resection rates appear about the same. But if you look at each of these patients, these were very advanced stage 3 patients, 15-centimeter tumors invading chest wall and other structures. So I will just say the standard of care in unresectable disease is to give induction chemotherapy. Enough said. The last 6 of these that I've treated in the last 4 months have all come to me with stable disease, which I think means no response. After chemotherapy, they had a lot of neuropathy though. And I'm going to show all 5 of them, we see the same response. I'm just going to show 2 of them. This patient had a 10% tumor reduction after chemo. This is the post-chemo pre-radiation disease, 15 centimeters. And you can see the post-radiation volume right there. This is making an unresectable tumor now resectable. This is about an 80% reduction. This is another patient with stage 3 disease. You can see its intimate association with the SVC and the aorta. Stable disease after 4 cycles of chemo. After radiation, a 75% volumetric reduction. But look at the tissue plane. So we now have a tissue plane for resection that wasn't there before. So a really nice response to treatment. So This talk is simple. Post-op RT shouldn't be given in stage 1 disease. In stage 2 and 3 disease, it should be considered. When we think about stage 2 specifically, we should also take into account other factors such as histology. In unresectable disease, the standard of care is systemic therapy. And while borderline resectables are, per national guidelines, treated with induction chemo, the notion of concurrent chemorads is an intriguing alternative to consider in these patients. Thank you.